So before that, the chief digital officer at Jefferson Health System in Philadelphia for about 6 years, and then in another industry before that. So that's my background. AI, I've been working with AI since maybe 2002. Not something that I speak about a lot because it was in missile guidance systems. But it did end up in some good results because it got into Moffitt and then was used, the same AI was used to look at X-rays, because the construct was simpler than a satellite image of what to hit. So proud of that experience and excited about the future of AI in healthcare or any place, really, any industry.
Awesome.
First of all, pleasure to be here and good to have a panel of fellow panelists. My name is Divya Pathak. I'm the Chief Data and AI Officer at New York City Health and Hospitals, which is the largest public healthcare delivery system in the country. We serve over 1.4 New Yorkers. We're located in 7 acute care facilities and over 30 plus ambulatory clinics in and around New York. My exposure to AI, prior to Health and Hospitals, I was the vice chair for AI and analytics at the Center for Digital Health at Mayo Clinic. Prior to which I was in IBM research during the Watson Health days. So there's a lot of carryover from those days onwards. And in my current role, I support clinical and business functions in support of AI adoption throughout the enterprise at Health and Hospitals.
You guys hear me? Yeah, okay. My name is Yan Chow. I'm the Global Healthcare Lead for Automation Anywhere, one of the sponsors of this conference. Really glad to be here. This is my umpteenth time. I used to be, I am a pediatrician. I used to be the Director of Innovation at Kaiser Permanente globally, nationally, and which was kind of an unusual position at the time. After that, I joined Amgen as the digital medicine lead. And I joined Automation Anywhere about 5 years ago, just before COVID, to start the industry vertical there.
So what I really love about this panel is that you have payer, provider, pharma, pure tech, all covered. And if you throw me in, I've got a lot of government as well. But with people who have been doing AI for a long time. And for many of us, we think AI came out after ChatGPT. Reality is, of course, AI has been around for decades longer than that. But what is brand new is that this one area that I was bringing up is the idea of just because we need something done doesn't mean we have to hire more people now, right? That is a dramatic change, and that occurred in 2022. Okay, so it's only 3 years old, and in healthcare, that means it's only 3 seconds old, right? So for everybody else, it's years, but we count them in seconds. So now, having said that, let's start with that conversation. And so, do we agree that 2022 was a turning point in this concept in healthcare that more and more work is needed? We're not going to get more people, but that doesn't mean that the work can't be done with AI. Is that a statement that you guys agree with, push back on? We can start there. Remember, you guys can ask questions as well. Go ahead, Neil.
All right. You said that this work doesn't mean that this work can be done with AI.
It means that more and more work is coming. And workforce is leaving, retiring early.
Yeah.
We have a pediatrician who's just starting a startup, which means she's not working at her hospital like he was supposed to yesterday.
Yeah.
And this is reality, right?
Yeah.
People are leaving in droves, but the work is not stopping.
Yeah.
But I feel that instead of saying let's go get more workers, we have to say let's go get more AI with more agents along with more workers.
Okay.
Is that a valid statement?
I think that's a valid statement. I think we also need to reimagine the kind of work environment that we have for workers also. I think talking to Michael yesterday, maybe hospitals need to go out into the homes, right? And people will be more willing to go there and treat people, right? So that may be one thing that you do. Another, when we were at Common Spirit and COVID was raging, we set up virtual hospitals, right? Which weren't hospitals, really. They were buildings that we had in 3 different states, where it was easier to get workforce, right? That would be willing to not go into a hospital, but into a building. They were clinicians before. They'd retired, some of them, and so we were able to bring them back to still do the things they wanted to do with their lives, right? But they had left because they felt afraid of this thing that was, could kill them. So, but in a different environment, they were fine working and they could still do similar things that they were doing before. Because some of this, see, healthcare is a very personal kind of, almost touch-oriented profession, and so it's difficult to completely take everything into AI. Although I've been very surprised. So the other side of it, yes, I think AI can do a lot, especially in the back end. We've not really explored it. RPA did some of that, and then we got disillusioned a little bit by it. But now you take RPA and you put AI and Gen AI on top of it, and you can suddenly start doing a lot more. You can orchestrate processes, not just automate them. Um, and so there is that possibility into the future, and we're already doing some of this now. But at the front end, at that touch kind of end also of healthcare, I think you can use AI, but you have to do some uh, re uh, re-engineering of the way people work also.
Yeah, great point. So I'd love to hear either alignment or pushback to say, no, 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 it's way too early. We still have to do our normal staffing decisions independent of AI, or can we start making staffing decisions with AI?
I think I would agree. And most importantly, when you look at healthcare, right, always we end up jumping into clinical decision support. I think there's so many areas when we talk about workforce shortages. We really look at workforce shortages around the 360 degree of a healthcare ecosystem, trying to identify those low-hanging opportunities, certainly not requiring clinical decision support, which is more diagnostic, more treatment planning. And prior to that, there's a lot of prevention and proactive management of patients, which certainly can be a place where AI is less guardrails, safe to implement, and also reduces the administrative workload required. Talking about back office operations, we talk about financial productivity of organizations. So important when you talk about workforce shortages. So many middle and small sized hospitals are actually not able to actually have the reimbursements like before. Uh, are we able to actually look at increasing our revenue by looking at some level of automation using AI clearly, right? Identifying charges that could be missed for reimbursements. We could optimize the denials, number of denials. So when we talk about AI, impacting workforce, I think there's so many short hanging fruits that can be handled. Prior to having all the conversations related to how a generative AI can support clinical decision support, which requires a lot more guardrails, safer planning. It has to be validated for clinical efficacy prior to use. And most importantly, right, all the equity reasons for which, it becomes equally difficult to.
Yeah, and so these guys are talking about it more at the high level, but obviously this is what you do on a daily basis at Automation Anywhere. So talk about what are you seeing that kind of surprised you in the last couple of years, where somebody you didn't think that they would be able to do this, but now with modern AI and your new capabilities with Automation Anywhere, that you were able to do things that maybe keep staffing stable or reducing?
Yeah, I would agree with Divya and Neil. I think that basically, healthcare, I remember those days when you had a need for more work, you just hire more people. We used to have lots of people that would come and go, but the statistics are pretty daunting. I mean, everybody knows that by 2034, we're going to be short of, 100,000 physicians, million nurses. And in fact, the recent survey showed that they looked at hundreds of healthcare executives and asked them about their revenue cycle department.
Yeah.
And 25% of them said they were short 20 positions or more, and they could not fill them. And a lot of the healthcare regulations coming down the pike will hit the revenue cycle department.
Exactly.
So there's almost no choice. So there are barriers in things that have to be worked out. For instance, there's union agreements, there's staffing agreements, scope of practice agreements, things like that will eventually be worked out because healthcare is not sustainable currently. So I totally agree with
Let me double click on that for a second. So you're saying that if you were going to try to automate out the growth of some jobs, usually the first place to start is take the 25% shortage and say, we're not filling those, just going to keep them where they are. You have to pass those by unions, that decision?
You may have to, yes.
Really? Interesting.
The other thing is,
which just scares the shit out of me now.
again, it'll
I'll
take,
just be
Go ahead,
I mean,
please.
one of the things
Yeah, no,
that's
come back.
really,
Yeah.
I mean, you have to think beyond that.
Yeah.
So one of the things is, for instance, the reskilling issue, which we run into. So in the world of AI, what will help you make your job, what will help you be more viable in the future? So that's a different skill set. Instead of doing things yourself, you have to manage automations and software that does it, AI agents, which is the latest thing. For physicians, for instance, let's say we take away the administrative and the cognitive burden. That is the main target, for us, according to PwC and the NIH article and so on. What if the physicians now only have to deal with very complex, difficult cases? That is going to stress them out. So there's a lot of things to think beyond that, and I think that we're trying to keep lockstep with the progress of AI, but AI is going so fast, and it's going to be just like to take it out.
You were saying something then, Divya, and if there's anybody with questions, please ask. I'll come back to you one second. You wanted to say something?
I just wanted to point out that it's not just about the unions and those jobs. Sometimes there are requirements, to have a certain number of people, like with Medicaid and all that. If you're serving X number of people, you have to have X number of people serving them.
Because of contract
Yes,
requirements.
contract
I see
requirements
what you're
and
saying.
such. So, you've got to learn to work past that also, and then convince those customers that, no, you can run this with AI, and that may take a little bit of time.
Got it. Yeah, fair enough. Go ahead.
Graduate, School of Public Health, also through the School of Education and Social Policy. So, my perspective on, integrating AI and how we can, deal with physician shortages come from a perspective of how do we integrate that into the physician education. If we are, looking at essentially like replacing administrative burden, taking, all of these advances are so important. How do we educate physicians and maybe ease up? There's also the barriers to becoming a physician. Not only are you, how can we integrate AI into medical education and, make, while there's so much innovation? Yeah, that's kind of my question.
Go ahead, Divya.
So I'm right along the lines, but I'll also answer that question for you, right? Talking about what he had mentioned, reskilling and upskilling workforce and improving the change management processes is so key when you're trying to actually end up with having to deal with the workforce shortages, but also expecting the current existing workforce to support the volume with using AI. There's so much of change management and upskilling required. And so workforce adoption and trust in building AI and using AI has to be one of the key principles of governance. Right? It has to be a mandatory education. If we really are navigating this AI era across healthcare, having a mandatory training of basic policies to follow, what to use AI, what to not use AI, and also have persona level training for clinical staff, nurses versus physicians, right? Depending on the systems they end up adopting, that level of training has to be mandated in order to adopt the trust needed to establish. Talking about education, that's absolutely a key, right? But how are we also preparing the future generation to navigate this era when they're going to be the workforce entering in the future? It goes across, it's medical education, it's also from a technology standpoint, especially when you talk about health policy and informatics. Those are areas where AI has to be, it's now part of the foundational principles when it comes to professional education.
Wouldn't it be the same? Wouldn't it be the same, Divya, as when we were doing EHRs? There were places that installed an EHR and didn't do any training. Maybe those hospitals have already shut down, right? But there were places that, quote, did it right. Is that the kind of thing you're talking about?
That's exactly what I mean. I think when you talk about AI adoption, change management and training has to be part of that initiative. Can't be an afterthought. It has to be a forethought. Most importantly, because again, right, not everyone is AI aware or even AI trained in healthcare workforce. We're not talking about a corporate tech company building innovative products. We're talking about healthcare serving patients. So having that level of training as a forethought, building that as part of your governance when it comes to AI adoption, and any organization is key. And we're starting to do that because we realize, right, as much as we talk at a 50,000-foot level high information, people still need that level of understanding of how it impacts their particular operations. How does my workflow change? With imputing technology, what do I do differently? Right? Some basic questions does come up in each of the clinical workforce. We've got to tailor the education to them
Yeah,
before
love
we
it.
talk about improving, AI use.
Great point. Yeah, go ahead.
Are there any areas of automation or opportunities of automation you see that there's not enough focus or solutions coming your way in?
Or is everything oversaturated? That's the opposite way of looking at it. Yeah, and I think you probably see a lot, right?
Yeah, I mean, there are so many areas that we are not in. Um, and, in the past, and this makes a lot of sense, we were mostly focused on revenue cycle.
Yeah.
Because that's just mission critical for everybody. And the revenue cycle is still the major part of our business. But there are so many areas that people have looked at: credentialing, supply
Business
chain, contact center, HR and finance we've done, Gen AI applications, all kinds of things across the spectrum that have different levels of risk and different levels of priority. So you can kind of see that it'll take time. But the other thing I want to point out is that, when the EHR came in, one way it's different is when the EHR came in, imposed a huge administrative burden and a huge cognitive burden. And AI is a moving target. So now we're seeing signs that AI is going to make the interface less demanding, which means that I think that in the future, eventually AI will be invisible. That's where we're aiming.
Nice. Did that answer your question? Yeah.
Yeah,
Great.
I would love to know from the payer and provider perspective too, but
Oh yeah. No, go for it.
no
Neil,
obligation.
yeah, Divya.
Sure.
Any other ideas of open spaces or gaps available?
Yeah, I think so. Not just on the payer side, but just overall. I think I'm a human-centered designer, and unfortunately, that space is underserved. I feel, the experience part of it, trying to improve that organically on the fly, creating a connected experience for people so that it's not disjointed. Yesterday, some brilliant person here, I think maybe it was Michael. I'm pulling up on you a lot. Said that when you call an Uber, you get the whole car, right? In healthcare, it's like, okay, we have to get the wheels, the green together, and then it has to show up at your doorstep, right? Because it's all coordinated. It's like, different pieces coming together. And that's really tough. And that toughness shows in the experience because it's very disjointed, disconnected. You have to navigate it many times, like Ed said yesterday, on your own. And I think if we can apply AI to that, to work organically in that space would be awesome. And if it were invisible, even better, because then you would have this connected experience that you wouldn't even realize was being stitched together by AI.
Yeah, so the invisibility part there is interesting is that we already have these things called quote ambient AI, which is like these things are all ambient AI right now. It's listening to our conversation. It's being recorded on purpose specifically for transcribing, summarizing, etc. And in theory, that's of course it's I believe the number one thing that most hospitals and health systems are asking for. I bet the elite group and these guys can probably answer that. But if you take a look at the next step, it is the self-servicization of patient input, patient diagnostics, et cetera. So let's talk about that. I think administratively, you'd find very few people that would argue that we need to hit those. And I think you gave some really good examples. But as soon as we move beyond that, what about the self-servicization where I think that the AI tools in specifically diagnostics, not treatment. So let's push away the treatment side for at least several years. Let's just hit the administrative and patient diagnostics. Where do you guys see, like, what would payers be willing to say? You know what? If patients would use like the MedWand that they were showing yesterday, or other tools, what are you guys willing to think about and pay for? You don't have to answer officially for your company, but just say what are kind of directionally patient diagnostics that you might be willing to cover as a payer. And then Mayo has been doing advanced diagnostics for many years, so I'd love to hear some anecdotes there. And then from Automation Anywhere, how would you be able to orchestrate and pull all of that together so that if patients were doing self-service diagnostics and physicians were prescribing that capability, how would we be able to orchestrate it? So let's look at it thematically.
Okay. From a payer lens, I'm also a care provider. So,
Yep.
but for a payer, I always believe in following the incentive, right? So for a payer, the incentive is to keep you out of the hospital and out of an ER, right? And so definitely would be willing to cover diagnostic, early detection. They do that already, in a lot of different proven kind of
What are some
science
examples?
fields.
Like this is covered, like my wife got it covered for her.
Yes, it depends, though. It depends. It depends on what the condition is. If you have multiple conditions and something like that it depends on the science behind it also, because a lot of payers have been sold on a lot of things that many times don't really pan out, or in the real world kind of, they don't really pan out. So they're very cautious, innovation sometimes is not that easy, because the first question you might get is, oh, so who else is doing this, and so it can be tough that way, because they've been oversold on a lot of the promise of some of these technologies.
Does continuous glucose monitors fit in that? Or do you feel like continuous glucose monitors
No,
and CGMs
that's
are-
pretty well accepted, right? It's things like, let's say you're treating asthma, right? And you have a lot of new tech coming out that's going to listen to your lungs all the time and then tell you when you're going to have an attack possibly, or if a certain geographic location is bad for you, or certain type of exercise is bad for you. That's still an evolving science, right? And it's easily confounded by things like your clothing or things like that. So then they're a little bit suspect. Oh, really? Can I do that? The newer technologies with testing, for example, that folks are kind of consumerizing that side. So they get a little bit concerned about that. Is that going to result in a higher cost, or is it going to actually see benefit? Are people really going to engage? And another area that payers always want to be really well on top of is engagement, right? Having people take responsibility of their own health, also incentivizing them towards that. So I feel like in those areas, if you're diagnosed with a particular condition, they would want that. And there are technologies that do that, but they've also been oversold, with engagement rates that didn't work really in the real world. So that's the part I would say they might be suspect, but definitely pro trying to keep you out of the hospital, keep you out of the ER. And if something does that, or have you treated at home, offer a lot of incentives for that, even by your own relatives. Medicaid does that. So in certain regions. So I think very pro to answer your question. And
So two things you can add is you were giving some examples yesterday about advanced devices like in countries like India or Brazil
yes,
or
yeah,
Mexico.
yeah,
Give
yeah.
some of those examples. Like they sound crazy to us,
Yeah.
but it works out there and they use it for day-to-day
Yeah.
kinds of work. And then
Yeah.
talk about what would it take for a payer in the US to believe in those kinds of things? Is it a paper? Is it a New England Journal article,
Yeah.
peer-reviewed? Is it FDA clearance because you have to have a CPT code?
Right.
What would it be? What would that look like?
Yeah, so payers have a relationship and partnership with providers too. So apart from all the papers and all of that, it also has to be part of some kind of clinical practice.
Yeah.
Otherwise a provider is going to say, well, I don't care about this data,
Mm.
and ultimately they are the ultimate decision maker. I can't tell a member, oh, I think you need to take this medication, right?
Mm.
Because I noticed that you might be coming up with asthma or something like that. Yeah, I can't do that. So it has to be accepted that way too. And that's the problem with the research in India versus the research in the US, right? There are a lot of regulations in the US, and rightfully so. But in India, in some cases, that type of regulation does not exist, right? So, for example, when I was at Jefferson, we did a lot of work with a lot of very large health systems in India through our Global Jefferson effort for grants and the such. And I visited a bunch of them. And I'm originally from Goa in India also, so I know the health system there. But when telehealth kind of came out, not even telehealth, it's really weird. Like Steve Plasko always says, what do we call it telehealth? We don't call banking online telebanking, So, but we still consider it something separate from the norm, kind of, but there it was like the cell phone, Okay, well, if once the cell phone came out, everybody forgot about landlines, and they just went to the cell phone because landline situation was not so great in India. So the same happened with this, like when Teams came out and WebEx and all that. in rural areas, folks don't have access, and then once the geo network came out through Reliance, everybody got data included in all their plans. It just blew up, like I went to a hospital where I saw a person. There was a line in a village of mothers that were waiting to see these docs, and these docs are in the city, and they're just walking into this room with Teams and someone's camera, webcam there, and then they're seeing all these patients. Here it wouldn't work. You know? And they have devices now. They see the smartphone as this phenomenal platform for doing a lot of things. So there's
Yeah.
devices to like spirometers built in. You won't see that here
Yeah.
yet for quite some time. And
Yeah.
the investors only investing in India for that, so they can start that kind of research. I still think it needs to be controlled so that nobody gets, taken advantage of or gets something that's bad for them.
Yeah. But it could still be seen as a
yeah,
good leading edge.
as a
We'll
good
take this
leading edge, yeah.
question here,
Yeah.
then question that back there, and then we'll let these guys jump in as well. Go ahead. All right. Sharice is going to make you squirm. She's going to follow the rules.
I don't think they can hear me. So I work in an interesting intersection. I work in med ed, health IT, and policy on the other
Nice.
side, a lot of
Very
sides.
nice.
So what I'm seeing right now in medical schools and in training and residency, we're seeing probably the most vulnerable residents we've ever seen. So those are the ones who are now coming into the field.
Expand on what is a vulnerable resident.
They're not doing well mentally.
Okay.
Medical training is complicated as it is, but I think we're now living in a pre-pandemic and post-pandemic kind of way in medicine, and we're just seeing very vulnerable students and residents right now. So I work in that every day. But the other thing is on the policy side, things are changing rapidly. I couldn't really enjoy this conference yesterday because I was on the phone so much dealing with those type of issues. But the other thing is this idea that we can just bring more doctors into the field or don't fill certain roles. It's ridiculous. Right now, 33% of the specialties are leaving the field. They're going to be gone. And we need a way to help augment what doctors do every day so they don't hate doing what they do every day.
Yeah.
And one of the issues with that is if you want to build, I guarantee this, if you build a credentialing model that actually solves the problem, the world will write you a check. All of us in this room will write you a check because it is a process that I always say, if you guys have never read the book From Symptom to Diagnosis, credentialing is that thing.
So
You know what I mean? So it's like if you could build that out 100%, everybody would be the path to your door, right? So that's a problem we haven't solved that needs to be solved. It takes time away from doctors. It takes time away from systems. It costs money when doctors haven't gotten their credentialing done. And last year, I think I had the most amount of credentialing providers, builders and developers come to me for advice. None of them had solved that problem. And my question is always, what's your why? Why did you build this thing when the problem is actually this thing? So that's the other thing. What my question is with these three different areas of challenges, how are you selling to your organizations, to the CEOs, to the boards and that type of stuff, this idea that we need to invest in things that lessen stress on doctors, lessen transactional inefficiencies, because it's not a short walk. Most CEOs wants to know, how can we make money now? But we know with the problems we're having now, the solution is a long-term collaborative one. How are you selling these ideas to them? Or how do you package so you can say that this is what we need to look at now to ensure we tackle this problem in the future?
That's a wonderful question, right? Talking about does an organization, I'm going to speak for the health and hospitals that I'm part of, very deeply involved in identifying what are those priorities for the organization. So one thing I would speak about is what is the high pain points as an organization. We in health and hospitals, right? Our patient volumes are so high. We have increased waiting times for patients seeking a primary care appointment. So it's very important for us to focus on the clinical burnout related to it, because we read recently, if you've been following the city's news, we reduced the 40-minute primary care appointments to 20 minutes. Okay, that leads to increased clinical burnout, more administrative burden on the providers because you end up seeing more patients. And of course, patient experience is of concern because if you have more patients and you have less time spent with each patient, what is your patient experience and outcome? So those were areas that one of the initiatives, right? It's ambient listening we're looking at right now, is to see how do we bring such a technology to support the workflow. So that leads to increased patient experience, reduce clinical burnout, and some organizations, even though non-profit, I mean, health and hospitals is a city government entity, so we're not looking at financial productivity. But some organizations that's looking at financial gains would also be looking at ambient solutions as another priority. So I would say it's really depending on the organization's mission and what are the pain points in the organization. The second one we're focusing on is now radiology. You can ask, okay, why radiology compared to any other diagnostic support? It's only because it's the most matured, I believe, when it comes to radiology and imaging is one of the most mature technology that's gone FDA approval. There's several companies who have proven to use radiology imaging to support either incidental findings, finding abnormalities, which is helping in prioritization of cases that needs the most care, and also an early detection of critical conditions that might have gone unnoticed. So we understand, right, from reducing the diagnostic workload, identifying patients that's to be prioritized to be treated early, and early detection of some incidental findings, which could have been misdiagnosis. So we understand we're looking at several factors and looking at what's more mature in an AI space than trying to, I'm going to make it up, right? Find the next biomarker for Parkinson's disease. Not something an organization like Health and Hospitals is going to be focusing on. But are we looking at supporting the patient experience, reducing the burnout, handling the workforce shortages? These are all the areas based on which we identify those priorities. So I think it's very, very organization specific in what they focus on.
Yeah, and maybe what are you guys seeing at Automation Anywhere? Are you ever brought in to say, we're not sure what we're doing, can you help us out prioritize? Or you're like, when you walk in, they know exactly what they want to automate and they tell you, go handle it?
I think it's a mixture of both. I mean, I think there's so much hype around AI today that everybody feels like they're missing out if they don't at least hear about some use cases that they could do. But to the point about credentialing, and as you said, David, every organization is different.
Yeah.
The priorities today are pretty much revenue cycle. That's the highest priority. I mean, to survive, But credentialing is interesting. We've actually talked with a couple of organizations about credentialing. The issue with credentialing is it depends on a lot of things that are outside your organization. That's the issue.
Yeah.
We can automate everything inside the organization, but when the state doesn't give you access to the portal, when the recommendation letters don't come in, I don't know what you can do about that. So
Yeah.
it's a tough issue, but it is a real issue.
And
And
there
it
are
does fall to the income, the revenue question too. Yeah.
and there are companies handling that. So there's one that I know called Certify OS that does that, because we were evaluating right now credentialing software, and there were a few. Yeah. From what we do right now, absolutely. How accurate it is only once you get it
Yeah.
into practice that you see what that real world data is that you know.
I'm just going to add, credentialing, as you see, everyone talks about it as an automation and place where AI can be brought in. But those who've dealt with these use cases in organization, I can speak for it. It's larger than just an automation issue. It's actually data management at an organization level, right? Uh, Having a robust provider data management solution is key to having a good, accurate automation that's required to support credentialing, right? So that's why I always say data and AI are not like two different pieces. Robust data management is key to building better AI and better automation. So I just want to state that in addition to all the external dependencies, whether it's with the state or within your own organizations, you have multiple multidisciplinary groups when it comes to provider credentialing and enrollment.
Yeah, credentialing is an HR hiring problem, right? So, yeah, whoever's got the mic. Sunny, you got the mic, and then with the next gentleman back there.
So I completely agree. Credentialing is a big issue.
Yeah.
But I don't know who's going to solve this problem. It doesn't make sense, right? I mean, if you are graduating as a physician, you should be allowed to practice anywhere in the US. I've never come across any other field where, let's say you're an engineer, you have to then be licensed for a state to be an engineer. So I don't understand where we have all these shortages, and especially when we're talking about virtualization of care, but then you're only licensed, you have to have credentialing in all the different states. Doesn't make sense. And I don't know who's going to solve this problem and whose incentive to solve this problem.
When the shortage actually occurs, I mean, we all complain about shortages, and there are real shortages, but the reality is the licensing is a protection racket, right?
Yeah.
It's a known racket for decades, and protection rackets get broken up when an actual need occurs, where a senator needed care, but somebody said, "Hey, senator, you would have had care, but credentialing failed, and you didn't have a doctor." That's how it's going to change. I mean, so we can all talk about the tech and everything else,
Yeah.
but it's mostly useless because it's not
I
really
think
valuable.
the other aspect that I wanted to talk about is like, I understand that, you're reducing the time from 40 to 20 and it has a burnout. I think the challenge I feel is someone coming from the outside who's, I don't know if you're in the healthcare, you don't see the pain that an average person goes through. If you try to look at, I mean, I've had to help so many people where they were not getting appointments for 2 months, right? Someone had an eye problem, and the first appointment they were getting was couldn't see. This happened to my architect, right? This is in US. I mean, I one of my architects had to fly down to India to get his back MRI done because
Yeah.
had all these bottlenecks. I mean, this is now reality, right? And none of this comes through, and it's really sad. I mean, to see this kind of state that we are in, and I think we can talk about. So the question and I see the promise with AI is, can we instead of trying to get more patients to see the doctors, can we use AI to prioritize to see how many of these really are true issues? And can we use it to prioritize patients to see the physicians? So you're not really creating a whole bottleneck, but I think there are different ways to solve it. And I just feel that uh, we are still solving the wrong problem.
See, I- just to respond to that, right? I'll say we're we're not looking at a hospital for the well-being of the patients ahead of time. We're looking at it being a sickness, right? When the patient is sick is when they come to the hospitals. I think your point is valid. Looking at prevention strategies, is there a way where we are able to use AI to identify, the risks, stratify those patients, provide proactive management of care so that there is less patients even visiting a hospital. So preventative care. I know we have a few members here talking about patient engagement ahead of time, right?
Yeah. So
That's an area. There are definitely certain care management.
no, but I would say that the problem with patient engagement is there is no CPT code or billing code that pays for it. So I think it's empty words, honestly. And I think the people that have, like you gave an example for India, right, where people are using iPhones to detect, ear infections and other things. I think some of these things, if someone doesn't have access to care, that care is better than no care.
Yeah.
And I think a lot of times, and that's where the state we are in.
Yeah.
And I think most healthcare systems are kind of out of reality. And unfortunately, patient population doesn't have choices,
Yeah.
and they're stuck with whatever they get.
Yeah. Yeah.
And I think that's a real challenge. So I
Yeah.
think where I think as leaders, I think one needs to look at how can you make those changes in your organization and not wait for global policy change.
I'll just respond to your question about proactive care management. It's important when you look at value-based. When you're talking about value-based population is focused on patients' well-being, not on patients' treatment in a hospital. I think there is importance to keep them outside the hospital for which you can.
Yeah, I mean,
Yes, it's going back to also tying back to all your reimbursement model. But it is true that
yeah,
there are value-based population that needs proactive care.
and that's a great point, and this is a point that we made many times yesterday, and we should make it all throughout the day. Anybody who's got a bright idea has to prefix it with, and here's how we'll pay for it.
Yeah.
If you don't, your bright idea is useless, right? Because it's not very bright at all. It's quite dim.
Yeah.
And then we do that all the time, right? We go and say, well, why doesn't somebody do this? And why doesn't somebody give me free pizza when I go to the pizza shop? Well, because that guy wants to get paid.
Yeah.
And every answer to all of our problems starts with, and this is how I'm going to pay for it. And if you don't have that, then we have to reorient our thinking
Yeah.
that says, we'll find the money.
Yeah.
And here's the bright idea, right? That's great. So there's one more last question. I think we have 1 more minute left. Go ahead, please.
So there's been a lot of discussion around AI as it relates to process and to data analysis, workflow sort of optimization. I think we're on the cusp of a brave new world around AI in terms of its empathetic capabilities. We know for a fact there are patients now, because there's such a long wait time, they are going to ChatGPT for services, right? I'm curious, from each of your perspectives, how are you thinking about this empathetic ability of sort of the interpersonal capabilities of AI across, whether it's from an insurance perspective or the system perspective?
Yeah, yeah. So I'm quite surprised by it actually, because during COVID I was driving a lot from my house in Tampa to my house in Jersey, and so because we couldn't fly, and so along the way I used to stop at a friend's house who became a doc, and so she was a psychiatrist, and in the evenings for Atrium actually, so in the evenings she would tell me, oh well, I gotta go now, gotta go to work, and I was like, but you're not going anywhere. No, I'm doing these calls all the way till like 7 a.m., right? From starting at 11 or so, she was going all the way till 7 a.m. And she had actual appointments. I looked at her list, at 3 a.m. in the morning. So, that's because people needed for mental health issues needed her at that time, right? And then I have a friend from back in India when I was at the Tata Group, left and then started her own company, and it does mental health services using bots. I thought it would never work, but it's worked phenomenally. She's selling to Aetna or a lot of US companies now, because people need that kind of, and as you said, they either go to ChatGPT or they're going to these types of services. And I went through her product, and you can bring empathy even through systems. You have to train them. You can't just let them go free, unsupervised, and then do whatever. I think that's really, really important. And then I know you mentioned earlier, I was itching to answer this about capacity, and I'm experiencing that right now. My wife wants an appointment since October. She gets one in February, and she's like worried throughout this time now. And there are companies, you said about incentive, right? Why is someone going to give you a free pizza? That we are not optimizing our load of actual appointments also.
Exactly.
And so someone has to show you, here's how you're not doing it. Here's what would happen if you gave up your specialty triaging with Anna on the phone or whatever, right? To a system that actually can learn from that and then actually balance your appointments better, so that someone like my wife can get an appointment like, instead of waiting 4 months, in 2 months, and it actually benefits you, because the current system is not working even for you, right? There are companies like ClearStep that are doing that, others, even shifting into the home, care into the home, helps you balance that. You said that yesterday when we were talking. So my question to you was, well, does it take away business from your surgery? And you said, no, surgery is how Mayo actually earns a lot of what it earns, right? So the more surgery it can do, the better, right? And so for people that don't need the surgery, if they can be taken care of in the home, that's even better. So you have to shift these models, but people don't get it. The current CFO class doesn't get it. They see a building and they want to build that building and put a bunch of people in it. And that's unfortunate. So you have to build that and show it to them. It's more education of those people than the clinicians, really.
And that's a great way to summarize here. And we're going